Welcome to today's explainer. We're going to take a geographic journey straight through the intricate landscape of the human ear. If you've ever dealt with an earache or, been kept up at 2 in the morning by a screaming toddler who has one, you know just how intense this localized pain can get. So today, let's step inside the anatomy and figure out exactly why that happens. Let's kick things off with a pretty provocative question. What biological quirk makes kids natural magnets for these painful, recurring infections? Most of us know that kids get ear infections all the time, right? But very few people realize that it actually just boils down to simple plumbing and gravity. We're going to solve that mystery in just a few minutes. So here's our roadmap for today. We'll be covering 1. The outer ear, 2. The middle ear, 3. Clinical detective work, 4. Dangerous complications, and finally 5. Medical solutions. Let's just dive right in. Section 1. The outer ear, also known as otitis externa. We're starting our journey right at the external acoustic meatus, the outer ear canal, to look at a condition classically called swimmer's ear. And you've got to see the pathogen's playbook here, because it's fascinating. Your ear canal is lined with skin and a protective wax called cerumen. This wax barrier maintains an acidic pH that bacteria absolutely hate. But say you introduce a lot of moisture, like from swimming or living in a super humid climate, or you aggressively use cotton swabs, you strip that cerumen right away. The pH suddenly flips to alkaline. Opportunistic bacteria, most commonly Pseudomonas, exploit this immediately. They sneak in, triggering intense inflammation. The canal swells up, traps fluid, and creates this dark, wet, alkaline breeding ground where bacteria just multiply like crazy. So what does this actually look like in a patient? Well, the classic symptom is otalgia, severe ear pain, but the real dead giveaway is physical movement. If a patient totally cringes in pain when you tug on their outer ear, the pinna, or push on that little cartilage flap called the tragus, you are almost certainly looking at an outer ear infection. Movement literally stretches that inflamed, swollen skin. When a doctor takes a peek with an otoscope, the ear canal might be red and oozing fluid. We call that otorrhea. But the eardrum itself, the tympanic membrane, it actually often looks perfectly normal. Section 2. The middle ear, otitis media. Traveling past the eardrum, otitis media operates under a completely different set of rules through this wild cascade effect. Middle ear infections almost always start somewhere else, usually just a standard viral cold that causes an upper respiratory tract infection. That viral infection travels up and inflames the Eustachian tube, the tunnel connecting the back of your throat to your middle ear. When this tube swells shut, the middle ear simply can't ventilate. It creates a negative pressure vacuum that physically sucks the eardrum inward. Then fluid begins to build up in this trapped space. This fluid stasis is kind of like leaving a bucket of water out in the summer sun. It's an open invitation for natural mucosal bacteria, like Streptococcus pneumoniae, to superinfect the space. Eventually, the pressure flips, the fluid builds up so much, and the eardrum literally bulges outward, screaming in pain. Which brings us right back to our opening question. It turns out a child's anatomy is literally working against them. Think about an adult's eustachian tube. It's angled downwards, which allows gravity to just pull fluid down into the throat. But a child's eustachian tube, it's horizontal, shorter, and much more floppy. It naturally traps fluid far easier than an adult's does, making it the absolute perfect storm for blockages and bacterial breeding. All right, Section 3, the clinical detective work. Let's put on our clinical detective hats for a second. We have 2 distinct infections here, one outside the eardrum, one inside. By directly contrasting the two, the picture becomes crystal clear. Like we noted, pain upon pulling the outer ear points straight to an external issue, otitis externa. But in otitis media, pulling the outer ear doesn't usually hurt at all because the infection is safely walled off behind the eardrum. However, when the doctor looks inside, they won't see a normal eardrum. They're going to see an angry, red, bulging tympanic membrane. The pressure is trapped inside, actively trying to push its way out. But what if the patient is experiencing hearing loss? To solve the puzzle of where the blockage actually is, we use tuning fork tests, specifically the Weber and Rennie tests. And here is a truly fascinating quirk of human anatomy. In conductive deafness caused by a swollen outer canal or a fluid-filled middle ear, bone conduction actually beats out air conduction. Normally, sound travels best through the air of your ear canal, but when that path gets blocked by swelling or fluid, a vibrating tuning fork placed directly on the skull bone bypasses the blockage entirely, vibrating the inner ear directly. The patient will remarkably hear the bone vibration louder and longer than the air vibration. Wild, right? Section 4. Dangerous complications. Unfortunately, the narrative takes a bit of a dark turn when these localized infections just refuse to stay put. When bacteria aggressively breach their biological borders, an everyday earache turns into a medical emergency. For the outer ear, the most terrifying complication is malignant otitis externa. This typically strikes vulnerable populations, like poorly controlled diabetics or immunocompromised folks. The Pseudomonas bacteria don't just stay in the skin. No, they sneak through these tiny anatomical gateways in the ear cartilage called the fissures of Santorini. Once they're through, they infect the skull base itself, causing osteomyelitis, a literal bone infection. This brings on severe nocturnal pain, and it can even paralyze the facial nerve. In the middle ear, an infection can actually spread backward into the honeycomb-like bone right behind your ear, known as the mastoid process. When bacteria invade these mastoid air cells, they destroy the delicate bony walls, melting them down to create one massive coalescent cavity of pus. This is mastoiditis. And get this, the sheer volume of swelling in that mastoid cavity actually pushes the entire outer ear outward and forward. It creates a dangerous, highly visible abscess right behind the ear that requires immediate, aggressive treatment. Then there's another totally bizarre middle ear complication, the cholesteatoma. Remember that negative pressure from a blocked Eustachian tube we talked about? Well, over time, chronic negative pressure literally sucks a portion of the eardrum backward, creating this deep pocket. Slowly, this pocket fills with a brown mass of dead skin cells and keratin debris. Now, this mass isn't a tumor, but man, it acts exactly like a biological wrecking ball. It expands, erodes into the middle ear, destroys the delicate hearing bones, the ossicles, and leaks a highly distinct, foul-smelling drainage. But the ultimate nightmare scenario is when a middle ear infection decides to go up. The roof of the middle ear is this super thin layer of bone called the tegmen tympani. If an infection creeps through that bone and into the brain lining, you are dealing with a full-blown central nervous system emergency, like meningitis or a brain abscess. You absolutely must watch for red flag symptoms here: soaring high fevers, a stiff neck, extreme nocturnal pain, sudden facial paralysis, or cortical signs like seizures or even losing the ability to speak. If you see those, it requires immediate neuroimaging. And finally, Section 5, Medical Solutions. So how does modern medicine cure these nightmares before they can breach those borders? Well, for outer ear infections, doctors rely on topical antibiotic drops. But you have got to be a careful clinical detective here. You can use powerful neomycin drops to kill off the Pseudomonas, but only if the eardrum is perfectly intact. Why? Because neomycin is heavily ototoxic. If the eardrum has ruptured from all that pressure and you put neomycin in the ear, those drops are going to wash right into the middle and inner ear, potentially causing permanent, irreversible hearing loss. So if the eardrum is ruptured, the doctor must switch to a safe alternative, like ciprofloxacin drops. Now, for middle ear infections, we obviously can't use drops because the eardrum blocks them entirely, so oral amoxicillin is our heavy hitter. But what about those kids whose horizontal Eustachian tubes just keep failing them? Chronic pediatric cases might actually need a surgical procedure, where tiny myringotomy tubes are placed directly into the eardrum. It's a brilliant fix. It bypasses the faulty Eustachian tube entirely, manually venting that persistent pressure and allowing the fluid to finally drain out. And of course, if we see those terrifying spread complications like mastoiditis, we immediately escalate to heavy IV antibiotics or even a surgical mastoidectomy to literally carve out the infected bone. Understanding this anatomical journey doesn't just demystify the extreme pain of an ear infection. It leaves us totally marveling at the delicate, interconnected machinery of human hearing. The ear is an absolute marvel of engineering. But as we've seen today, its very design features, from the wax barriers down to the tiny ventilation tubes, can easily be hijacked by something as simple as trapped moisture or a basic cold. So the next time you feel that deep, muffled pressure, ask yourself, is this an intruder in the canal or a pressure cooker trapped behind the drum? Thanks for joining today's Explainer, and keep questioning the incredible machinery inside your own head.